Good afternoon, and I'm Bob Kushner from Northwestern University in Chicago, as Bill introduced me. And I'm going to talk about some other initiatives. I've titled it Educational and Professional Obesity Initiatives. I wanted to start with this slide. I and many others, some in this room and many others outside this room, have spent a great deal of their career trying to move this space forward. I think of it as a top-down and bottom-up initiative, and they have to be done in parallel process. When I say top-down, that is, how do we educate clinicians who are already in practice? They're not trainees anymore, they're in practice. What do we do to advance their game? We can create a subspecialty or focused practice. I'm going to talk about that in a bit. We provide continuing medical education. That's how they learn how to do things in addition to reading journals and doing asynchronous learning online and so forth. But we also have to think about the bottom up, and that is, how do we train current trainees about obesity, the ones who haven't developed biases yet and have been exposed to the practice of care. And here we can develop domain competencies. You just heard about that. So all medical education today is competency-based. It's performance-based and competency-based, and that's what you just heard about. We have another parallel initiative called the Obesity Medicine Education Collaborative, or OMEC for short, in which we are also developing competencies with very specific benchmarks from medical school to residency to fellowship, and also for PAs and NPs. And then we also have the United States medical licensing exam, in which students are tested to advance in medical training. I wanted to focus on two of these out of the four that I've mentioned. And just one more point, why it's important to do parallel education. I come out of a nutrition background, and years ago we had a nutrition initiative for medical schools called the NAA, in which we did a very good job training medical students. And when the NAA was finished, nutrition education became fairly extinguished because the students responded to, the interns, the residents and attendings didn't know much about nutrition. So it really didn't lead up to its full completion. So unless we train trainees and people who they're responsible for, we're not going to move obesity forward. So we have to think in terms of all of those levels all at once. So I wanted to start off with an initiative that many of us done. You've heard from Lou Aroney earlier. Scott Gahan is also on this, who's a roundtable member. And we wanted to go to the exam that medical students have to take and residents have to take in order to advance their career. And although we don't like to think that people learn by what's on the test, people do learn by what's on the test. Testing should not drive assessment. But in reality, students always want to know what's on the test. So we wanted to know what's on the test when it came to obesity. So a panel of the 6 of us went to Philadelphia at the United States Medical Licensing Exam, USMLE. For those of you who don't know, it's a 3-step exam required for medical licensure. Steps 1 and 2 is taken during the 2nd and 4th year of medical school. Step 3 is taken during internship. The USMLE assesses an applicant's ability to apply knowledge, concepts, and principles and demonstrate fundamental patient-centered skills that are important in health and disease and constitute the basis of safe and effective patient care. That's right on their website. And it's sponsored by the Federation of State Medical Boards and the Medical Board of Medical Examiners. This is what we did. All the individuals, the staffing of the USMLE identified keywords. In other words, they pulled items for us before we arrived that had keywords like obesity, body mass index, weight loss, percentiles, and so forth. So they were selected. 6 of us went to Philadelphia under a locked room because it's all secret stuff, and went through all of these items. And we used the American Board of Obesity Medicine, which I'm going to talk about in a little bit, as a rubric in order to identify where these items were once we identified them. And I'm showing you the rubric on the bottom here. It's 107 possible domains. So we used that as the foundation. And I'm going to get right to the results. Out of the 802 items that the 6 of us reviewed, roughly a third of them really had any meaning. The rest of them were a patient with a BMI of 40 and then went on and had nothing to do with obesity. So we identified about 1/3 of the items actually were judged to be related to obesity. The vast majority of the items actually did not deal with obesity as a discrete illness or condition. It was primarily obesity with an associated comorbidity. So the items students are tested on is really type 2 diabetes, sleep apnea, metabolic syndrome, polycystic ovarian syndrome, rather than obesity itself. So the treatment really was, the question was about the comorbidity. Most of the items coded in 4 organ system categories. That wasn't unexpected. Cardiovascular, endocrinology, female reproduction, respiratory. Those are the bulk of the areas that students are tested on. 80% of the coverage of these items were limited to just 6 ABOM domains, and it primarily was, how do you assess a comorbidity that patients with obesity get, and how do you treat a comorbidity that patients with obesity get? That was primarily what it was all about. The current concepts of obesity prevention and treatment, including science, assessment, and management, were not addressed or hardly addressed at all. Our key recommendations that we put forward in our article was to recommend on the STEP exams that these items and these areas need to be added. Basic science, socioeconomic and behavioral determinants, assessment, diagnosis, treatment of obesity per se, behavioral medicine, pharmacotherapy, bariatric surgery, weight bias, and discrimination. We also encouraged them to use people-first language, which is what we are all doing today. They informed us they were already in the works of doing that, so we didn't have to convince them of that. And lastly, we recommended that obesity content experts be assigned to the USMLE item writing committees. And to their credit, they asked me, and I am now serving on the chronic care committee of this examination, in writing 40 items per year to enrich the pool, and I will be hopefully among many who will be doing that. I wanted to turn now to the second area, which is the American Board of Obesity Medicine, which you've heard about twice. Lou Aroney mentioned it, and it was mentioned once again. And the rationale for developing an obesity medicine physician pathway are listed here. I'll just read them out loud. The increased prevalence and burden of obesity and of overweight in the U.S. and adults continues to rise. It's recently been recognized as a chronic disease by the American Medical Association and other societies. We felt that certification would bring increased recognition and competency to the field and lay a foundation for improved reimbursement. Advances would be going on that needs a educated workforce. Certified physicians would serve as champions locally. And lastly, board certification would establish standards of appropriate knowledge in professional obesity. The saying, if you build it, they will come, we are delighted to see is true. Over the past 5 years, this has been the growth of the number of individuals who are now diplomats in the American Board of Obesity Medicine. Lou Aroney showed you how it's now surpassing on an annual basis the number of candidates per year of more recognized subspecialties like cardiology, pulmonary, renal, and so forth. We now have over 2,000 diplomats. On the right, you see the average distribution of medical specialties. It primarily consists of internal medicine and family medicine. It's the primary care clinician who is actually being certified. Over 50% of diplomats spend less than 50% of their time doing obesity medicine. In other words, they are your primary care clinician who is now also trained to provide obesity care. Also, about 60% of our diplomats have been practicing obesity care for less than 6 years, or less than 5 years. In other words, representing a new specialty. In June of this year, the Obesity Journal will be publishing our article on our 5-year report. Again, you see Lou Aroney and Scott Kahan. I want to shout out to them since they're both involved here today. And that's going to summarize the information I just gave you. So in summary, we have many initiatives that are going on to increase the workforce. They have to be done in parallel, and they have to be broad-based. Thank you very much.